Good morning, everyone. My talk is today on left main PCI two-stent approach. So how do we go about? We call left main a different animal. Why do we call it? Because it supplies very large area of myocardium, all 75 to 80% area of the myocardium is supplied by left main, very big branches. So whatever procedure you do, you produce lot of ischemia, which produces a danger of VTAC and heart failure. So you have to be very clear in terms of doing a left main angioplasty in a complex lesion where two vessels are involved and two stent may be an approach for that patient. So when do we do the two-stent approach? Mainly for true bifurcation lesion. What do we call two bifurcation lesion? 111 and 110 and 011. These are the three true bifurcation lesion, and all other are non-true bifurcation lesion. So amongst those two, do all of them require two-stent approach? No. We have to study whether the stenosis in the side branch is more than 70% or not, and length of the lesion is more than 10 millimeter or not. If it is not so, provisional stenting is fine. But if it is not suitable also, then still provisional, but keep the side branch open should be an approach that should be kept in mind by the operator, so that side branch is open. And side branch, if it extends the ostium, yes, then clearly elective two-stent strategy is very good approach. And in that, decay crush today works out to be the best in terms of long result. That I will show the results of the various trials that we have. And then provisional stenting if the lesion of the length is not much. Now, what are the various complexity that we should look into? Major is diameter stenosis more than 70% and side branch length of the lesion more than 10 millimeter. And of course, we have to see moderate to severe calcification. Most complex lesions do have that. Multiple lesions in bifurcation angle less than 45 is a very important one, because if you do provisional, likely to be side branch closure is in the lower angle, less than 45. Moment you put this crossover left main to LAD, the side branch will close acutely. So you have to be very careful if the angle is very narrow. Then main vessel, that is left main reference vessel diameter is less than 2.5 millimeter. The two thrombus containing lesion and the main vessel length lesion more than 25 millimeter. These are the various complexity criteria. Now, once we decide that this is a complex lesion, then two-stent strategy is correctly approached, and decay crush is the preferred technique. And ABC consensus, we all have heard of EBC consensus, but ABC consensus is a part of EBC consensus. What it says, wire both the arteries, prepare both the lesions well, and stent should be optimized at the end. That's the very important message. Whereas if the lesion is not complex, it's a simple lesion, then of course consider stent, single stent as per the ABC. And if there is a side branch occlusion, then of course T-tap or reverse culotte. Now, physiology becomes a very important aspect. If you put a crossover stent and you see side branch stenosis, evaluate by physiology. If it is not significantly narrowed, then you can leave it with the medical treatment. If it is significantly narrowed, then of course two stent. So 20% of the provisional required two stent at the time, bailout stent, at the time when you are performing a procedure. Now, how does the anatomy matters? Suppose if you have a left main and side branches of equal size, this is a good anatomy for culotte technique, two-stent technique. If you have a side branch bigger, one side branch bigger than the other one, then crush techniques are ideal for that anatomy. And if side branches are of equal size and there is a landing zone available, then V-stenting should be considered. And of course, for T-shaped bifurcation, we should consider provisional stent and if necessary, do tap. Unless the side branch access is difficult, if side branch access is difficult, then you have to stent the side branch first. So what other thing that we need to look at apart from anatomy, physiology? We need to look at the side branch size. If it is more than 3 millimeter, clearly two-stent strategy, which may be modified T technique, SKS, T-stent, tap, or culotte, or decay crush technique. Any of these technique can be used, but preferred is decay crush if it is upfront. Decay crush cannot be used as a bailout technique. We all know that. So if the diameter of the side branch is 1.5 to 2.9, then consider, if there is a calcium, consider a cutting balloon or rota, and only stent the main vessel, and maybe do DCB here for the side branch. And leave the DCB, if a DCB impression, in case there is a restenosis yet, then we can save that branch for the second stent for the next procedure if ISR occurs. Otherwise, medical therapy is the ideal if the size of the vessel is very small. What are the trials saying? Trials saying that if you look at the MACE rate, the lowest MACE rate is with the decay crush. We can see that very clearly, no doubt about that. Then coming to cardiac death, myocardial infarction, target vessel revascularization, stent, thrombosis, all the trials are in favor of decay crush. So decay crush upfront strategy, if it is there, decay crush should be considered. It cannot be used at bailout, as I said multiple times. Now, what is the current approach? What do we follow? What do we follow is, if we have an unprotected left main and we see that angiographically there is a lesion, we should do FFR and IVUS and see that if it is critical or not. If yes, then look at the syntax score. If it is more than 32, CABG. If more than 32, but STS score is high and patient is not suitable for CABG, heart team approach and left main PCI. If left main lesion is distal, yes, then true bifurcation lesion or not, yes, then decay crush. If no true bifurcation lesion, then provisional left main stenting should be considered. If all this is very important, because all the trials have proven that decay crush upfront is very good for true bifurcation lesion, and bailout, all the techniques are available, and the best result in bailout are either tap or thing. Now various technical tips to get a long-term good result is the balloon size. Kissing has to be a proper. Then two-step kissing is very important. That side branch where you have multiple layers of the stent, inflate a high pressure DC non-compliant balloon and see the result are far better. You see the p-value difference is huge. And of course, the narrow angle is one of the very troublesome area where you have a long-term fatigue of the stent if there is a narrow angle due to shear stress. So take-home message is PCI is valid alternative for low and intermediate syntax cover. No doubt about that. Provisional technique should be considered for non-true and the true for true bifurcation, two-stent technique. Decay crush seems to be very favorable. Imaging guided PCI is strongly recommended for use of PCI in left main particularly, and use of dedicated large size stent with a higher radial axial strength, radial strength is preferred. So in conclusion, I would say that stent treatment of true bifurcation, left main stent, coronary artery disease, is very effective treatment, no doubt about that, particularly if syntax score is low and intermediate. If it is high, then very complex lesion with calcium, then of course surgery not possible. That's where the PCI results are slightly compromised unless the results are very, very good long-term results and stents are properly optimized. So between the provisional and two stent strategy, complexity of the lesion should be considered and morphology should be kept in mind. And operator's knowledge, skill and experience and judgment is of paramount importance in successful PCI two-stent strategy. Thank you.